All right, it's my pleasure to give you a talk entitled Diagnosis of the Patient with Headache. And actually, having practiced for about over 20 years in the headache field, what you really learn is that the diagnosis of headache is primarily made by the history. And the variety of different headache disorders that I will present in the following lecture, many of them will be diagnosed by just simply history alone. So with that, we'll go to the second slide. The International Headache Society has developed the International Classification of Headache Disorders 3 beta version, and this is really the Bible of diagnosis of migraine. This is actually the third rendition. The first rendition was in the late 80s, the second rendition was in the early 2000s, and now this is the third version of this. And this provides us the template for diagnosing a variety of headache disorders. Now when you look at how they break it up, they actually have a code for each headache diagnosis. And the first several relate to primary headache disorders. Those are headache disorders in which there's no secondary cause for them, like a brain tumor or vascular event, etc. And you'll see that 1.1 to 1.6 are migraine, and the 2.1 to 2.4 are attention hepatic. I'm not going to go through all the codes, but you can see that there are different codes for different diagnoses within each category. Then you hit what we call the secondary headache disorders, which are headache disorders which have another cause to them, like a brain tumor or a bleed or whatever. And you can see a variety of codes that range anywhere from 5.1 up to 14. Now when you talk about the primary headache disorders, this kind of goes into this very point that we talked about before. They're both primary and secondary. So the primary headache disorders include things like migraine, tension type headache, and the trigeminal autonomic cephalalgias, which we'll talk about. That one of those is called cluster headache, and there's a variety of other ones as well. And then there are other primary headache disorders like cough headache and exertional headache and so forth that we'll go over as well. The secondary headache disorders are those that are the result from another cause. And as I said before, those are things like brain tumors, subarachnoid hemorrhage, dural venous thrombosis, etc. All right, so we're going to first talk about what the ICHD-3 calls 1.1 to 1.6. So these are the migraine diagnoses. And I'm going to present a number of the ICHD specific criteria for each of these disorders, but that's not what I really want you to remember. They're really here more for your reference. But I've highlighted in red the areas that I think are most important. So when you talk about migraine without aura, there are about 7 things that you really have to remember. The first is duration. The duration is 4 to 72 hours. And the second is there are 4 clinical characteristics that migraine patients have to have at least 2 of those 4 to meet criteria for migraine without aura. So those are unilateral location, although unilaterality only occurs in about 2/3 of all migraine patients. A pulsating quality, which occurs in about 60%. Moderate to severe intensity. And finally, aggravated by activities such as walking or climbing stairs, by routine physical activity. And then they have to have either one of 2 associated symptoms, either nausea or vomiting is one grouping, and the other grouping would be both the presence of photo and phonophobia, which is sensitivity to light and noise. So if you actually remember those 7 criteria, then you can actually diagnose migraine without aura. Now migraine with aura is slightly different, so only about 15 to 30% of all migraine patients actually have an aura, and it's defined by very specific criteria. So there's called migraine with typical aura, and that includes a visual, sensory, or speech or language symptom as the aura phenomenon. And the things you need to remember about an aura are, it gradually spreads over greater than 5 minutes. And you say, well, what does that really mean? So if you have like a sensory aura, so the numbness might begin first in the face, it might go down into the arm, it might later go down in the hand. So it's basically a marching of symptoms that occur over about 5 minutes. And that's the main way you differentiate an aura from a TIA or stroke. There's a characteristic duration of a typical aura. So the typical aura generally occurs 5 to 60 minutes. And then finally, the headache phase is accompanied by a headache within 60 minutes after the aura has occurred. So those are the specific criteria, and no other cause for it is found. Like for example, rarely brain tumors can cause an aura, or other arteriovenous malformations can cause auras as well. So that's assuming that those disorders have been excluded. Now this is typically what occurs with a migraine aura, or a visual aura. This is actually a scotoma or blind spot, and you'll see that at 1 minute, 5, and 15 minutes you see this gradual enlargement of the scotoma, and often around that blind spot is a geometric shape, that's basically a hatched area. It's often crescent shaped, and it'll gradually progress to the point where if you actually hold your finger up in your temporal field, you may not even be able to see your finger during that time period. So you see the gradual evolution of aura, which we talked about in the previous slide. Now there are also other auras as well. There's something called typical aura without headaches. So basically you can get an aura and not have the headache. And this commonly occurs as people age, and we used to call them late life migraine accompaniments. It's almost like it's a friend of the migraine patient. Sometimes patients that are older that have actually had no history whatsoever of migraines before they start developing these auras. Oftentimes they're not. They may not. In this diagnosis, they're often not accompanied, or they're not accompanied by a headache within 60 minutes. There's also something called migraine with brainstem aura, which is 1.22. This used to be what we called basilar type migraine. They've now renamed it. They actually now say that there's a brainstem aura, although I think, frankly, there's very little evidence that there actually is an aura in this, but this is what it's called, where you have to actually have two other symptoms along with your migraine. So you have to have either a dysarthria, vertigo, hyperacusis, diplopia, ataxia, or some decreased level of consciousness. So you have a lot of basically vertebrobasilar symptoms along with the migraine. There's something called hemiplegic migraine, which comes in both the sporadic and familial form. And that's basically where you get motor symptoms. So you get a motor aura. So you get weakness of your arm and your leg, or just of your arm, and it's fully reversible. But they also may have other aura symptoms as well, which include visual, sensory, and/or speech or language problems along with these motor auras as well. And then there's something called retinal migraine, which is a reversible monocular. So it's a monocular, either scintillations, scotoma, or blindness. So you can have some people that will actually have complete blindness of one of their eyes as an aura symptom, and then later the migraine or the migraine headache may occur within an hour as well. So these are the subtypes of other aura other aura diagnoses that one might encounter. Now with the familial hemiplegic migraine, which we talked about before, there actually now are 3 gene mutations that have been shown to be responsible for familial hemiplegic migraine. Most of these are channelopathies. So the CACNA1A gene is the alpha. It encodes for the alpha-1 subunit of the PQ type calcium channel. And there's also an ATPA2 gene mutation, which codes for the alpha-2 subunit of the glial neuronal sodium potassium channel. And then finally there's a SCNA1A gene mutation, which is for a neuronal sodium channel as well. So there are a variety of mutations which have been found to cause familial hemiplegic migraine. Then finally, chronic migraine is similar to a migraine without aura or migraine with aura, but it's different in terms of the frequency. So these are patients that have migraine. They have 15 or more days of headache of any kind, and of which 8 of which have migraine characteristics. I'm not going to go through all the different criteria and how you identify those migraines, but it's slightly different than the criteria for migraine without aura. But those are probably the 2 things to remember: greater than 15 days per month, and 8 of which have migraine characteristics and/or respond to a triptan or ergot. There also are what they call the complications of migraine. Those include status migrainosus, with migraines lasting greater than 72 hours, persistent aura without infarction. So those patients have auras lasting greater than a week. And I've had actually some patients that have auras lasting for months would fit into this category. There's something called migrainous infarction, where you have an aura greater than an hour, and then you get an infarction in the relevant area where the aura occurred. And then finally, there's something called migraine aura-triggered seizures, so where you might actually have a migraine aura and then later have a seizure, or the so-called migralepsy. There also are periodic syndromes that may be associated with migraine. Many of these occur in children. There's something called cyclic vomiting syndrome, abdominal migraine, and benign paroxysmal torticollis. What I've done is I've included the diagnostic criteria for probably one of the most common ones, namely abdominal migraine. What you do is, usually young kids will have these paroxysms of abdominal pain, usually in a midline location, periumbilical or poorly localized. They'll have a variety of different symptoms which may be attributed to migraine, including anorexia, nausea, vomiting, and pallor. And they have to have at least 2 of those symptoms. These attacks last for 2 to 24 hours, and they have to have complete freedom of symptoms in between attacks and no other cause found for these. And I think abdominal migraine may actually be more common than we've previously recognized. Now the second most, actually the most common headache syndrome is tension type headaches, and they fall into the ICD-3 codes 2.1 to 2.4. And tension type headache is the most common disorder. Prevalence studies suggest it can occur in anywhere from 30 to 78% of the population. There's a slight female predominance, but not so much as what we see with migraine. And the socioeconomic impact may actually be greater than migraine or other headache disorders, just by the fact that it is such a common headache disorder. Now the key thing is it's broken down to a variety of different categories. This is infrequent and frequent episodic tension type headache. I put the ICD-3 code 2.1 and 2.2. The key things about this diagnosis I've highlighted. It generally lasts anywhere from 30 minutes to 7 days. And it's like the exact opposite of migraine, or the exact antithesis of migraine. So migraine is typically unilateral in 2/3. This is bilateral. Migraine is throbbing. This is more pressure-like or tightening in quality. Migraine is moderate to severe. This is more mild to moderate. Migraine is aggravated by routine physical activity. This is not. And then they also generally tend to lack the associated symptoms that we see with migraine. There's usually no nausea or vomiting, at least with infrequent or frequent episodic tension type headache. But they can either have either phono or photophobia as an isolated symptom, not both together, and still meet criteria for infrequent or episodic tension type headaches. And basically, it's frequent episodic if they have 1 to 14 days per month on average, and it's infrequent episodic if they have less than 1 day on average. Chronic tension type headache is primarily diagnosed by the frequency of these tension type headaches. So if they have more than 15 days per month with these headaches, and then they meet all the other criteria we just talked about for tension type headache. But what's interesting is that they can also have some mild nausea. They can't have moderate to severe nausea, but they can have mild nausea but they have no more than either photo or phonophobia as an isolated symptom, which is somewhat confusing because you can see there might be some overlap between chronic tension type headache and chronic migraine in this situation. But nevertheless, this is the current ICD-3 criteria. Now, the trigeminal autonomic cephalalgias are a very interesting group of diseases, which include things like cluster headache, as well as Hemicrania Continua and other diagnoses. But the main differentiating feature for these is the presence of cranial autonomic symptoms. So I put the picture on the left of the autonomic symptoms. That would include parasympathetic symptoms like rhinorrhea and lacrimation, and sympathetic symptoms such as actually sympathetic hypofunction generally, where you get actually atosis and you get meiosis as well. So you're actually getting, in most cases, the parasympathetic system hyperactive, and you're getting the sympathetic system more hypoactive on the involved side. And the other thing is the duration. These headaches are really diagnosed by the duration, whether you're dealing with these short-lived headaches or more long-lived headaches, which we'll talk about. Now, cluster headaches have a characteristic duration. They have these ICHD code 3.1. These headaches last a characteristic duration of 15 minutes to 180 minutes, and they generally have at least one of the following symptoms. They have either conjunctival injection and lacrimation. Another category would be nasal congestion and rhinorrhea, eyelid edema, and then meiosis and orthosis. And what's interesting about cluster headache is often they have this sense of agitation, whereas migraine patients tend to lie in a dark room and be rather quiet and still. These patients are pacing. They're rocking back and forth. Sometimes they'll beat their head up on the wall. So what you see is that to make the criteria, you have to have the characteristic duration, one of two of the associated symptoms, which I've listed all of them in the slide, or a sense of restlessness or agitation as well. And the attacks have a frequency of about 1 to 8 per day. And it's not accounted for by another ICHD3 diagnosis. This is a picture of a typical cluster patient from the Netter's Atlas, and you can see a variety of different features. You can see the ptosis and meiosis on that side. You can see the periorbital edema. You can see the distension of the temporal artery on the right. You can see the sweating on one side, and you can also see the rhinorrhea coming out of the nose on the right side. And that's a pretty classic picture. So as we said before, there's signs of both sympathetic hypofunction, which include the partial Horner syndrome, meiosis, and nasal congestion, and then there's a parasympathetic hyperfunction with lacrimation and rhinorrhea. Now they're both episodic and chronic varieties of cluster headache. The duration is really primarily by the duration of the headache. So it's episodic if they have these cluster attacks anywhere from 7 days up to a year, and then it's chronic if they have a duration greater than 1 year. And what they say is, the key thing is that it's, at least with episodic, it's separated by pain-free remissions of less than a month. So you could have cluster headaches and then you could have like 29 days of a remission, but then the cluster comes back. That would still be considered one cluster attack, and so forth. And the same thing would be true for chronic clusters. So you can have up to less than 1 month of days with no headache, and it still represents a cluster period. There's something called paroxysmal hemicrania, and there's both an episodic and chronic variety. So the episodic lasts from 7 days up to a year, and the chronic lasts for up to 1 year. But the key differentiating feature of this headache is you get cranial autonomic symptoms with a short duration. And the duration lasts anywhere from 2 to 30 minutes. Now you may notice that there seems to be some overlap between cluster headache and this diagnosis, because cluster was 15 minutes up to 4 hours, and then, or I'm sorry, up to 3 hours, and then this one goes from 2 to 30 minutes. So there can be some overlap between cluster and paroxysmal hemicrania. And you can see the same type of autonomic symptoms that with cluster headache in this syndrome as well. So you get the conjunctival injection and lacrimation, and you get the nasal congestion and rhinorrhea as well. And the attack frequency is slightly different than cluster. So cluster was 1 to 8 attacks per day, and this is a frequency above 5 per day. So this tends to be a more frequent type of headache than cluster headaches. And this headache is very sensitive to therapeutic doses of indomethacin, although in this disorder you may need to give higher doses, anywhere from, say, 50 milligrams up to, some people even go up over 200 milligrams with indomethacin to treat this disorder. So this is one of the indomethacin-sensitive headaches. There's also something called short-lived uniform neuralgiform headache attacks as well. And these have at least, they have to have at least 20 attacks fulfilling these criteria. So you basically get severe unilateral head pain with supraorbital, orbital, or temporal pain. And you get the same type of symptoms. You get the conjunctival injection and lacrimation, nasal congestion, etc. You can see all the different autonomic symptoms that we talk about. And the attacks have a frequency of at least 1 a day to more than half the time when the disorder is active. And it's not accounted for by another diagnosis. So these are very, very short-lived headaches. So 1 minute up to 60 seconds. So it can go up to 10 minutes. And there are different subtypes. There's one called SUNCT, where all you get is, with your cranial autonomic symptoms, is conjunctival injection and lacrimation. And there's another called SUNA, where you get the full range of cranial autonomic symptoms, including conjunctival injection, lacrimation, nasal congestion, rhinorrhea, and facial sweating. So basically you get more autonomic symptoms with the SUNA, whereas the SUNCT just involves just very specific symptoms. Hemicrania Continua is a much longer duration headache, and this is a strictly unilateral headache, so it's side-locked. It's just on one side of the head. It's been present for about 3 months, And you get the same sort of cranial autonomic symptoms. So you can get conjunctival injection, lacrimation, nasal congestion, and rhinorrhea. You can read the same list. It's the same list as we've been showing before. Just like in cluster headache, they get this sense of agitation or restlessness where they may rock back and forth and so forth. And it responds very well to therapeutic doses of indomethacin, like we talked about with some of the other indomethacin-sensitive headaches. It's also not accounted for by another ICHD3 diagnosis. Now I provide this table here more for your reference because it kind of gives you the differentiating features between all the different headache disorders we talked about. So we talked about SNOOP, we talked about SUNA, we talked about the chronic paroxysmal hemicranias, cluster headache, and Hemicrania Continua as well. And these are all the differentiating features. So I give this to you more for reference. You can see that the SUNC and SUNA tend not to respond to indomethacin. There's different drugs that are thought to be first line, like gabapentin for SUNA and lamotrigine for SUNC. Although that can vary by person. You can see that indomethacin is good for the chronic paroxysmal hemicranias and Hemicrania Continua, and cluster headache is usually treated with corticosteroids and verapamil as first-line therapies. So there's slightly different therapies, different durations of the headaches, but they all have different variations of cranial autonomic symptoms. Now we're going to go into what they call the other primary headache disorders. These are codes 4.1 to 4.10. This is called primary cough headache, and this is something that we see not uncommonly in a headache clinic practice. But these are headaches that are basically brought on in association with coughing, straining, or other Valsalva maneuvers. And the key thing about these is they're rather short-lived headaches. So they last anywhere from a second up to 2 hours. And typically when you have a cough headache, you're going to want to rule out things like a Chiari malformation or other secondary causes of increased intracranial hypertension, brain tumors with a mass effect, and so forth and so on. So you're going to want to get MRIs, and some patients would actually do, or some physicians would do an MRA to exclude intracranial aneurysms in this situation as well. But once those have been excluded, you can make that primary diagnosis. There's something called primary exercise headache. These are people that get headache brought on by exercise. So these are headaches that are only brought on or occurring only after very strenuous exercise. That would include things like running. It could include weightlifting and so forth, and they last less than 48 hours. So you can see that there's not a lot of criteria that really distinguish these types of headaches. They're solely brought on by this particular activity. There's also primary headache associated with sexual activity. They used to break it into a pre-orgasmic and orgasmic type headache. They used to think that the pre-orgasmic often occurred in the neck, and it was kind of a tightening of the neck muscles and so forth. And then orgasmic occurred right at the time of orgasm, and people would develop headaches. When you get the latter type of headache, often in the past we were worried about intracranial hemorrhage or subarachnoid hemorrhage, and often that will necessitate both an MRI and MRA for diagnosis. But the official criteria are that they've actually done away with pre-orgasmic and orgasmic headache, and now they lump them both under primary headache associated with sexual activity. And these headaches are brought on by and occurring only during sexual activity or other Valsalva maneuvers. And the key thing about these headaches are they have to have either or both of the following. They have to actually either increase in intensity with increasing sexual excitement, which is what you would in the past have called pre-orgasmic headaches, or have the abrupt explosive intensity just before or with an orgasm, which is what we used to call orgasmic headaches. And they last anywhere from 1 minute to 24 hours. They have a severe intensity, but the headaches may actually have a milder intensity for up to 72 hours. So these things can last for much longer than the severe pain. There's something called primary stabbing headaches. These are what we used to call ice pick headaches. And these headaches can occur for up to a few seconds, even up to a few minutes actually. There's the key thing, differentiating feature between these headaches and say the SUNC and SUNA, which we talked about before, is the lack of cranial autonomic symptoms. And we call them ice pick headaches because it's like a sharp jab of pain. I will tell you that oftentimes these headaches will occur in the temporal or parietal region, and they're often occur in conjunction with migraine headaches. So you'll develop a migraine headache, and then during the migraine you'll get these sharp jabs of pain, or you'll have a history of migraine and you develop these ice pick headaches. that occur in migraine patients, but they may not actually have a migraine headache when these occur. Hypnic headaches are headaches that occur primarily in the elderly, although I've seen some patients with hypnic headaches that are much younger than that. But they develop only during sleep, and they basically cause awakening as well. And the key features of these headaches is they basically last for 15 minutes up to 4 hours. So if you have a headache that lasts longer than that, then it's probably not likely to be a hypnic headache. And the other key thing about these is there are no cranial autonomic symptoms or restlessness, because oftentimes patients with cluster headache will often have headaches that wake people up in the middle of the night. So consequently, if you don't have any cranial autonomic symptoms, that would rule out that diagnosis, or at least make it very unlikely. Now, the hypnic headaches tend to be treated with caffeine, which seems counterintuitive, because if you load up on a lot of caffeine prior to bedtime, you would think that they may not sleep. And I guess if they don't sleep, they wouldn't develop hypnic headaches as well. But other therapies that have been tried include things like lithium, and things like indomethacin may be given before sleep can also sometimes be effective with hypnic headaches. Hypnic headaches primarily have a female predominance. The mean age is approximately 60 years of age. They have a characteristic location. They occur mostly in the frontotemporal, or they're in about 46%, or they're generalized in 46%. Duration is about 162 minutes. Frequency of attack, the average was, in this study, was 20 attacks per month. And there seems to be a characteristic time. About 58% had these attacks occurring between 2 and 4 a.m. And you can see the treatments, some of which we talked about in the previous slide. New daily persistent headache, or what I often tell fellows and residents, is kind of a garbage diagnosis. It's really made by the history. So the headache basically occurs at one time, and basically it is a continuous headache that doesn't remit, basically. So it's distinct and clearly remembered onset. So oftentimes the patients will tell you that headache began on February 2nd, 2011. And the pain becomes continuous and or unremitting within 24 hours, and it has to be present for 3 months. These headaches tend to be really refractory to therapy, and often can be they're very difficult on the patient, so they cause a lot of disability and so forth. We don't really know what causes new daily persistent headaches. Some people have thought that possibly infectious causes can do it. Some people have thought the disease of the cervical spine. There was a study by Todd Rose that suggested that cervical hypermobility, such as you see in Ehlers-Danlos patients, might be associated with this disorder. But typically they're treated much like chronic migraine. Now we're going to go on to the secondary headache disorders. This is actually a mnemonic that was developed by Dave Dodek called SNOOP. And the S stands for, these are actually red flags for secondary headache disorders. So the S stands for systemic symptoms, so basically unexplained fever or weight loss in a headache patient, or headache in a patient that has a history of HIV, history of cancer, history of immunosuppression like transplant patients as well. The N stands for neurologic symptoms and abnormal neurologic signs. And basically what we found is that particularly abnormalities on neurologic exam may actually be some of the most potent predictors of a secondary headache disorder. Onset would include things like sudden, abrupt, or headaches that occur very suddenly, particularly headaches that occur and reach peak intensity within less than a minute, which is what we call thunderclap headache. Older patients refers to new onset headache and or progressive headache in older patients. And so if you have a new onset headache after age 50, that would be considered a red flag. And then P stands for previous headache history as well, is basically you have some change in an existing headache pattern. So if you have a migraine patient that always had headaches in one location, and all of a sudden now the headaches have changed in character, or the headaches are very refractory to therapy, then you may consider that as well. And then there's actually two other P's which are not on the slide. One is for positional headaches, so headaches that are worse standing than lying would be something called low pressure headaches, which we'll talk about later. And then the other one is papilledema. So if someone has papilledema, then you think about two diagnoses. One would be some condition causing increased intracranial pressures, or pseudotumor cerebri, or idiopathic intracranial hypertension is another word for it as well. All right. So when you look at the time course of secondary headache disorders, it really depends on how fast the headache occurs. So if you have one that evolves over minutes, you think of vascular causes. If it occurs hours over days, you think of infectious causes. If it's weeks over months, you think of more kind of inflammatory neoplastic causes. Or if it's greater than, if it's several months or a year, then you can think that it's more likely to be a primary headache disorder. So the time course of the headaches can be very helpful for differentiating secondary headaches from primary headache disorders. Now, one of the most feared headaches is something called thunderclap headache, and there's both a primary thunderclap where there's no cause found, or there's a thunderclap headache that suggests a very ominous type headache. And these are headaches with the following characteristics. So the headache reaches peak intensity in less than 60 minutes, tends to be a very severe pain, and it could either represent a subarachnoid hemorrhage or sentinel bleed, but there are also other etiologies in which this can occur. So they can have dural venous thrombosis, pituitary apoplexy, crash migraine, or carotid dissection. So there's a differential besides just a subarachnoid hemorrhage that could cause these types of headaches. Now when you ask yourself what test to order, there's a variety of different tests that one could potentially get. But if you're just trying to, and it really depends upon what you're concerned about as well. So if there's trauma, or if you're in the hospital for a thunderclap headache, particularly in an ER type setting, then where you suspect subarachnoid hemorrhage, or if you're worried about an osteomyelitis, then the appropriate test would be a non-contrast CAT scan. On the other hand, for most other situations, an MRI is the test of choice. So if you're worried about malignancy, a brain abscess, a cerebritis, or Chiari malformations, an MRI is indicated. And if you want to pick up, if you ask, well, when do you give gadolinium with the MRI? Well, if you're worried about a low-pressure headache syndrome, the dura will often enhance in that situation. Or if there's meningeal disease, or if you're worried about metastatic disease and or leptomeningeal carcinomatosis, giving the gadolinium contrast makes a lot of sense. Now, when you order an MRV, you're worried about a cerebral venous thrombosis. If you do an MRA, you're looking for things like dissections of the artery and or saccular aneurysm. So really, which test you order kind of depends upon what diagnosis that you're actually entertaining. When to do a lumbar puncture is the following: when there's a suspicion for meningitis, when you suspect intracranial hypertension, when you have vasculitis, other infectious etiologies such as you're worried about neurosyphilis, or whether you're worried about non-infectious inflammatory disorders like sarcoidosis, lupus, or other causes like vasculitis. Now we're going to talk about a headache attributed to trauma and or injury of the head and or neck. Those are ICHD-3 codes 5.1 to 5.6. So this is what we used to call post-traumatic headaches. Now it's called persistent headache attributed to traumatic injury to the brain. And the key things you need to remember in this situation is there needs to be some trauma to the head. And it doesn't have to be some huge trauma. It could just be some minor trauma, where some accident where they were driving 15 miles per hour and then just stopped abruptly, and you get some sort of flexion extension injury to the head. And what's interesting is oftentimes the traumas tend to be rather minor. Now you can also get these with more extensive injuries, like a blast injury, like a military veteran might get in war. But the key thing about this diagnosis is the headache has to start within 7 days. So with post-traumatic headaches, or this what they now term persistent headache attributed to traumatic injury to the brain, the headache has to occur within 7 days after this purported trauma. And it has to persist more than about 3 months. And you can see the other criteria on the slide for this diagnosis, but those are the ones that you probably should remember. Next, we're going to talk about headache attributed to cranial and or cervical vascular disorders, 6.1 to 6.9 ICD-3 codes. And this is one called giant cell arteritis. Now what's interesting is in the official criteria, they said that giant cell arteritis has been diagnosed, but they don't really tell you how it's been diagnosed. Usually it's diagnosed with a temporal artery biopsy. And the headaches generally last anywhere from 1 second up to a minute, and you can read the other criteria on the slide. But what I've done is I've provided you with some other diagnostic criteria. These are actually they're older criteria, but they were developed by the American College of Rheumatology. So you have to have age greater than 50, headache with no history of headache, although you could theoretically have temporal arteritis in a patient with migraine or some other primary headache disorder. Presence of some temporal artery abnormality, so that would be beating of the artery, some aneurysmal dilatation of the temporal artery. They use a cut point of 50 for the set rate, or positive biopsy showing mononuclear cells or granulomatous information. And if you have 3 of those 5 criteria, they found there was a sensitivity of about 94% and specificity of 91% for temporal arteritis. This is actually showing some giant cells in the wall of the temporal artery on temporal artery biopsy. And this is a very interesting study where in 2002, this Smolana looked at the likelihood ratios, both positive and negative, for a diagnosis of temporal arteritis based on a variety of different symptoms and or other lab tests. And what they basically found was that jaw claudication was the most predictive of all these features noted on the slide for predicting temporal arteritis with a likelihood ratio of 4.2, which is actually very high. So if you have headache and jaw claudication in an elderly patient, a headache that's new, then you might want to think of temporal arteritis. Now, headache attributed to cervical artery dissection, basically, just like with temporal arteritis, they say that this has already been diagnosed, so that's not particularly helpful. But the other things I think that are important is that the pain precedes the symptoms of acute retinal or cerebral ischemia. So basically, the headache begins before the neurologic symptoms begin, because with an acute carotid dissection, you can actually get stroke-like symptoms as well. So the headache begins prior to that. And the pain is unilateral and or ipsilateral to the affected cervical artery. So those are the main characteristics for cervical artery dissection. The key thing that causes most people to think about this is a partial Horner syndrome, where you get both ptosis and meiosis, as demonstrated on the slide. This is an example of a cervical artery dissection. You can see the actual arrows showing the cervical artery dissection, particularly in the panel on the right, left as well, with the arrow. Next is a headache attributed to a non-vascular intracranial disorder. These are codes 7.1 to 7.8. And this is another very common headache disorder called, this is what we used to call pseudotumor. The new criteria call it headache attributed to idiopathic intracranial hypertension. And the key things to remember about this, I've highlighted on the slide. The CSF pressures need to be greater than 250. In these patients, and there's no other explanation for that, like some intracranial tumor and so forth. Oftentimes, the way this will be detected is by the fact that they will often have papilledema, and you'll have a normal MRI of the brain, and in that situation, you'll consider this diagnosis. There's no criteria for any weight-based criteria, but this headache often occurs more commonly in obese women. It's an example of the papilledema that you would see on examination. Next headache disorder is headache attributed to low cerebral fluid pressures. This is also a headache disorder that's getting more recognition within the headache community. These headaches have a characteristic description. Generally, they tend to be improved lying down and better lying up, although if you've had these headaches for a long period of time, you can lose the positional component of these headaches. The key criteria with the ICHD criteria are that you have a low CSF pressure, less than 60, and or evidence of CSF leakage on neuroimaging, although they don't really tell you which neuroimaging to get. These patients often have dural enhancement, which is shown on the arrows on this slide, and that's thought to be from venous engorgement. So when you get a leak, the brain basically sags down, and you'll get engorgement of all these dural vessels, and that can cause the dural enhancement. There's also headache attributed to intracranial neoplasm. So this is basically a headache attributed to a brain cancer, either a primary or a metastatic disease of the brain. So in this case, just like with the other disorders, it has to be diagnosed, and then there has to be some evidence of causation between the tumor, and or in the headache disorder, and you can read the criteria that are on the slide. Just an example of a meningioma. You can see that in the white on the slide. What's interesting about brain tumor headaches, a lot of the things that you were told about brain tumors in medical school is just frankly not true. Many of the time, headache only occurs in about 36 to 86% of patients. So there are many patients that have headaches attributed to a brain tumor actually have a brain tumor that don't have headaches at all. They resemble tension-type headaches most of the time. They also resemble migraine headaches as well. The pain can be intermittent and often resolves over several hours. It's unilateral in 25 to 30%, and if it's unilateral, it does predict an ipsilateral malignancy. And if the tumor is in the posterior fossa, it's more likely to cause headache than if it's not in the posterior fossa. They used to tell you, like, worse in the morning, worse with bending, worse with Valsalva, interferes with sleep, occur rather infrequently with brain tumor headaches. And even straining and or movement only increase the pain in about 18 and 7% respectively, depending on which study you look at. Now, headaches attributed to colloid cysts, so you can get colloid cysts of the third ventricle. And so basically, it's the same type of theme where you have to have a colloid cyst demonstrated. And then there has to be some temporal relationship between the colloid cyst and these headaches. And these headaches can also be positional as well, as this cyst flops in and out of the third ventricle. This is just a picture of the colloid cyst. Headaches attributed to substance abuse and or withdrawal. We're just going to talk about a few of the highlights in this. This is 8.1 to 8.3. This is actually headaches for medication overuse. So basically, the criteria for medication overuse headache, you have to have greater than 15 days per month of headache of any kind. And then they have different cut points depending on which medication is being overused. So if it's ergots, triptans, opiates, or combination analgesics, you have to have 10 days, not 10 doses of use per month. If it's simple analgesics like acetaminophen or anti-inflammatories, you have to have 15 days per month. Now, these are headaches attributed to disorders of hemostasis. This is 10.1 to 10.7. This is called sleep apnea headache. This is also fairly common and probably should be suspected in any patient whose BMI is, say, over 30 and has headaches, particularly if they have morning headaches. So these are headaches are present upon awakening after sleep, and sleep apnea has to be diagnosed with an apnea-hypopnea index greater than 5. And I'll let you read the other criteria, but those are the highlights for sleep apnea headache. Now, when you look at sleep apnea headache, if you look at a sleep apnea group, about 48% of those people actually had headaches. Those with headaches had lower minimum SaO2s than those that did not have headaches. They also had higher apnea scores. The mean apnea score was 25. Apnea-hypopnea index was 25 versus 13 in those that didn't have headaches. And then comparing patients with OSA versus insomnia, headache on awakening was more common. So if you have someone that has headache on awakening that's obese or that snores or that has observed apneic episodes at night, you may want to consider this diagnosis. And it often resembles tension-type headache. So in conclusion, the precise headache diagnosis can be made with a careful history and physical examination in most cases. Use of neuroimaging and lumbar puncture is performed when there is a suspicion of a secondary headache disorder. And then finally, the ICHD3 criteria provide a guide for the diagnosis of headache disorders. Thank you very much.